Rheumatic diseases are painful, inflammatory, autoimmune, and degenerative diseases that are more than just aches and pains. They affect all age groups and vary in severity. Reducing pain, maximizing function, rheumatic diseases, tonight on Call with the Prairie Doc. Good evening and welcome to another episode of On Call with the Prairie Doc, medical information based on science, built on trust. I'm Dr. Kelly Evans-Hullinger, your Prairie Doc host. Tonight we will be discussing rheumatologic diseases. Thank you for joining us. In the studio this evening on the campus of South Dakota State University in Brookings is Dr. Vivek Joseph from Sanford Rheumatology Clinic, and via Zoom is Dr. Jennifer May from Rapid City Medical Center. Welcome, doctors. Thank you so much for joining us. Dr. May, you're a many-time guest on the show, but can you remind our viewers what you do out in Rapid City, how long you've been around?
Yes, so I've been practicing rheumatology in Rapid City for about 18 years, if you can believe it. I currently am in private practice, myself and a PA at the Rapid City Medical Center, and I see anything basically in terms of rheumatology, from autoimmune inflammatory arthritis, vasculitis, lupus, osteoporosis, osteoarthritis, but primarily outpatient practice. I'm from Rapid City originally, did my residency at Medical College of Wisconsin and then my fellowship at Mayo Clinic before I moved back home to raise my family.
Yeah, great. Thanks for joining us again. Dr. Joseph, you're a transplant to South Dakota.
Oh, yes.
Tell us about where you're from and your path here. How long have you been in Sioux Falls?
Perfect. So I've been in Sioux Falls for about 5 years. So I'm from far away from here, originally from India. Did med school in India, did a few rotations in the United States during my final years of med school. Decided to come here to subspecialize. So I went to New Jersey initially, did my internal medicine residency at Rutgers. Then went on to do a fellowship in rheumatology at Drexel in Philadelphia, and then came to Sioux Falls for my first real job, and I've been here for close to 5 years now.
Great. I'm excited to talk about rheumatology. I love this topic. But before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about rheumatology. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for our newest Prairie Doc publication. The winner will be announced at the end of this program. Your question will remain anonymous, but please provide contact information when you submit your question. So let's get to it. Let's talk a little bit about, we did get an email question saying, how is arthritis diagnosed? And I guess let's dovetail that into what are kind of the main subtypes of arthritis, because everyone's familiar with joint pain and arthritis, but what's the difference between inflammatory or autoimmune arthritis and your more typical wear and tear arthritis? Can you start?
Absolutely.
Vivek, yeah.
Yes. So in rheumatology, our first step when I see a patient with arthritis, obviously patients have questions on what kind of arthritis I have, and how we differentiate things in rheumatology at least. So the first thing is we differentiate between an inflammatory versus a non-inflammatory arthritis. So an inflammatory can be broadly 2 types. There are exceptions to the rule, but on average they are either autoimmune in nature, so basically your immune system is attacking the joints and causing inflammation. Most common would be a disease like rheumatoid arthritis.
Sure.
And the other subset would be a crystal-driven arthritis. So basically there's a foreign body sitting in the joint that should not be there, and that's driving the inflammatory response. So the difference between the 2 of them is here there's something different in the joint, your immune system's working as normal, while the other one, the joints are normal, but your immune system is confused, thinks that the joint is a bad person.
Yeah, good. So I feel like a common question I get in primary care, Jennifer, is my hands are sore. I know someone who has rheumatoid arthritis. I think that's what I have. How do you take that patient who maybe has hand pain and maybe their joints look abnormal, and decide whether this might be osteoarthritis or an inflammatory arthritis?
Yeah, I mean, you start kind of with the basics. So lots of times, when did it start? Has this been something you've been having for years and years, and it's been gradually worsening, versus you never had joint pain till about 6 weeks ago? So that would differentiate kind of degenerative or wear and tear type versus inflammatory. That would point that way. I ask people, how do you feel in the morning? Are you real stiff? And particularly, does activity help? So with mechanical stuff, if you have low back pain, it's mechanical, your back starts to hurt, you get off your feet, sit down, rest helps you. If you have inflammatory joint pain, like your hands are inflamed, they're stiff, you want to use them. The more you use them, the better it gets. So for inflammatory things, use is helpful, whereas for mechanical stuff, the more you use them, the more they hurt, generally speaking. So morning stiffness, onset of symptoms, how activity affects it, all those things can help direct you. And then location, because in your hands in particular, degenerative arthritis affects certain joints and inflammatory arthritis affects another set of joints. So there's a pattern that we can look at, and that's just from the history. And then obviously when we examine you, you can kind of feel the difference. And that just comes with time, of course, is what we do, but you can kind of feel if they have inflammation versus more degenerative, kind of lumpy, bumpy joints that really don't have fluid or swelling inside of them. Range of motion, when I move them, does it hurt versus when it only hurts when you move them? That can help you differentiate whether this is more tendon versus joint. So there's a bunch of different ways that help us kind of zero in as we're talking to you, and we can do that very quickly, actually. So that's probably the start to kind of put you on a path, those questions.
Yeah, good. And then, I might have patients ask, well, does lab or x-ray help you? And does it in these cases?
Yes.
Sometimes?
Yes and no.
Yeah.
So x-rays, it all depends on how severe the disease is and the duration. If somebody comes in to see me with 6 weeks of arthritis, not the most severe rheumatoid arthritis, you probably won't see anything on x-rays. Might help differentiate other causes of arthritis. If you're having a lot of degenerative arthritis, I can see the joint space is narrowed, so might help me rule out more than rule in.
Sure.
Labs, if it's positive, would very much suggest, again, unfortunately not a slam dunk in the field of rheumatology. Really, there's no perfect lab test that says things are in and out. What the patient tells me, what I feel, makes a big difference. And in those patients of ours where it's a maybe, I'm not really sure, is it a seronegative disease, for example, your labs are negative, I'm not seeing the full-blown inflammation, but I'm getting a story that makes me think maybe, then we add additional diagnostics. We usually do a lot of musculoskeletal ultrasound in the office so we can get an answer while the patient's in the clinic.
Yeah, good. So some of those just expert exam maneuvers are really helpful. So we had a great question. Why would you be referred to a rheumatologist? So Jennifer, what are the common reasons that you get new referrals?
Just broadly, I would say sometimes it's exactly what you just mentioned, which is just abnormal blood tests. So someone reported some symptom at an exam, someone ordered a panel of some sort, and then some of it comes back abnormal, so they get referred. So that's one way. The patient obviously is maybe describing joint pain, joint symptoms. A lot of it is going to be symptoms, and if the symptoms are really impressive, like rash, high inflammatory markers, that's going to get a referral. But a lot of times it's, patient reports some symptoms, a clinician orders some lab work, some of the lab work's off, they're not sure if it's clinically significant, and they want an opinion. I would say that's certainly not all of our referrals, but it's certainly a chunk.
And we were just talking, when we were talking with the students earlier, Vivek, a lot of the referrals you get, you might do your workup, do your exam, and decide this probably is not a disease that falls under the umbrella of rheumatology, and either send the patient back to their primary or somewhere else with some guidance.
Absolutely.
That happens quite a lot in your clinic. Yeah.
I mean, we deal with a set of diseases that have overall a fairly low prevalence among other conditions. It's nowhere as common as high blood pressure or diabetes. So hard to think of a percentage, but I would say it's almost a 50-50 toss-up. If somebody comes in, obviously there is a concern, and we have a new patient visit, usually it's about 60 minutes on average, to really see is there an inflammatory arthritis or some other systemic autoimmune disease versus is it something else? Is it something else that maybe it's better to see an allergist for if it's a rash, or orthopedics for joints? So we have to guide patients in the right way if it's not something that we treat.
Yeah, good. Well, we did get an email about gout, and I feel like I see a lot of gout. I like hearing your guys' take on it. So the email says, my husband has been getting gout several times. So a couple questions on that. What causes gout, and how can we treat someone who gets it repeatedly? So you want to start? What is gout, Jennifer, and what causes it?
So I love gout, actually. As a rheumatologist, it's so fun to take care of because it is completely treatable. So, that's always fun. We don't always get to kind of cure people, but gout is basically a metabolic problem. So if you have too much uric acid in your blood, so to speak, and that uric acid becomes a solid and kind of settles in your joints, and it likes to settle in the joints that have damage, usually degenerative joints. That's why the big toe is a common place, but it can happen anywhere. And to diagnose it can be a little bit of a challenge. People with gout get very hot, red, warm, swollen joints. They call you. They're coming in because they're uncomfortable. So tapping the joint and seeing the crystals is really the way to confirm it. But sometimes when you check the blood level, if it's really high, like the uric acid is 9 or 10, you're going to be like, I don't know how you don't have gout, and you're going to be very high risk for an additional attack, so you might address that. The treatment is sort of twofold. First, we need to lower your uric acid level to change the metabolic state. So you'll add a medication to do that. But the other is to treat these attacks, which are going to continue to happen even if you're on medicine. So it takes a while to slow the train down, right? We've got to get that uric acid down, and then we've got to get a process to manage your attack. And everyone's a little different about what maybe is the best attack plan. Like if you have a flare, whether it's an anti-inflammatory, adding in medicines like colchicine, but we create a plan for that. And over time, if you really educate your patient and help them understand that if they have a flare, it's not a failure of the medicine we gave them to lower that uric acid level, the attacks will become less frequent, less severe, and less often. And eventually they just won't happen at all. So it's a twofold approach of controlling the metabolic state, and there's a variety beyond medicine, losing weight, or there's some other things you can do, and then treating that attack to minimize attacks, because they're very disabling when they happen.
They are severe, and I get a lot of patients asking me about, well, can I change my diet? And classically, we learn about maybe some of these dietary triggers. What are they? Does it make a difference to change your diet, Vivek?
It depends on who the patient is,
Sure.
to be honest. If it's a patient is a young 21-year-old who's otherwise fairly healthy, clearly there's a genetic problem where your body's making too much of uric acid. If you are an older patient with bad kidneys, then yes, diet can help to some degree, but the real problem is your kidneys are not working, so the uric acid is not being gotten rid of the body. So basically it's a backlog, and you have to work to make your body better at getting rid of uric acid. You have that perfect patient who's just a little unhealthy, maybe a little overweight, maybe not the best diet, but kidneys are fine, never really had gout since they were a teenager, no strong family history of gout either, gets an episode of gout 1, 2, 3 times a year, they're the perfect candidate for, hey, let's not maybe start you on any treatment, let's try to see if we can bring down your uric acid, which is the primary problem of gout here. In gout, you have too much of uric acid, that uric acid goes into the joint, boom, you have gout. So the aim is to bring down your uric acid levels. Those are the ones that I will really focus on holistic, non-pharmacological or non-medication approach. I still will give them some medications to address the gout,
Sure.
but I'll talk about how to bring it down.
And what are the big principles that you tell them about?
Absolutely.
Then?
So the principle, so I like to kind of sit down and kind of talk pharmacology with our patients. So aim is to bring down the amount of purines you consume. So basically you want to cut down on animal protein, especially red meat protein is going to be the biggest one. I usually don't go through every food group and say, eat this, not that. I kind of give people kind of big ideas. So you want to eat less shellfish, eat less lobster, eat less shrimp, less beef. So basically less red meat and some sets of seafood work to bring down gout. I usually don't recommend any foodstuffs to bring down uric acid on its own.
Sure.
None of them seems to work that well.
Yeah.
Some of my patients swear by tart cherry, and I say, drink away with that. But usually I just recommend certain foodstuffs and see if you can bring it down. But I also see what the uric acid is. If your uric acid level is 12 and my aim is to bring it down to 6, diet will help, but you need medications. But your uric acid level is 7 or 8, you're my perfect candidate to work on your diet. And we'll check it again in 6 months and then make a decision.
Yeah.
Yeah.
Great. Well, lupus is an autoimmune disease where the immune system attacks healthy tissue and organs instead of protecting them. The attacks can cause inflammation and serious tissue damage. Prairie Doc reporter Sam Schauer spoke to a lupus patient who has had the disease since she was 16.
Melanie Taylor has been living with lupus since she was 16. It started in high school, where she started to experience symptoms.
I was having a lot of trouble walking, didn't know why. I was in pain all the time, constant fevers.
Taylor was soon taken to a hospital to be tested on what her pain could be. Her life changed after the diagnosis.
She said, you either have lupus or Lyme, or we're going to do some blood testing. And it came back and she goes, well, you have lupus. And I said, I have what? 16, of course, I'd never heard of it. And I promptly asked her, am I going to die? And she just giggled and said no.
Since then, Taylor has broken out into 2 flares. She says she gets aches and inflammation, hair loss, rashes across her body, and the butterfly rash on her face, which most people think of when someone has lupus.
Sometimes I'll have all those symptoms. Sometimes I'll just have 1 or 2, and it knocks you down for a few days on how bad the flare is. I have been down for a month because my flare was just so extreme.
To combat these flares, she takes a lot of medications, like prednisone for her aches and immunosuppressants to make sure lupus doesn't attack her body.
And then because I do have lupus, it has also affected my kidneys. I have to take blood pressure medicine because I also have lupus nephritis with that.
And while Taylor will have lupus for the rest of her life, she doesn't let it affect her anymore. And she sees it more as part of her and her story.
Kind of become part of me. Like, I don't as an illness anymore. It's more like, it's just my lupus. I have to do this because I have lupus.
Lupus can be a challenging disease to deal with. Are there things that you find tend to cause patients who have lupus to have flares, be it glomerulonephritis or any other flares, Dr. Joseph? Or does it seem to happen at random?
Some of it definitely at random. With the more serious manifestations like glomerulonephritis or basically kidney involvement or lung involvement or brain involvement, unfortunately it's more genetics than environmental. Really not a whole lot a patient can do. When patients have quote unquote more minor manifestations of lupus, more skin manifestations primarily or joint, then there are a lot of environmental triggers that can make it worse. UV light, so basically sunlight, is a big trigger for skin lupus. Both us and the dermatologists, big recommendations for anybody with lupus, especially with skin involvement, would be high SPF sunscreen, at least 50 or higher. with the South Dakota sun, wide brim hats, long sleeves, limiting amount of sun exposure is going to be the biggest environmental trigger that you can avoid.
Yeah, good. Well, I would like to hear what you guys have to say about a disease that I think about at least probably once a week in my internal medicine clinic, which is polymyalgia rheumatica. Can you give us the overview of what is polymyalgia rheumatica, Jennifer? Who gets it? What kind of presenting symptoms do people usually have?
So polymyalgia rheumatica, or sometimes you'll hear the term PMR, it's a really interesting phenomenon. People over the age of, I think the cutoff is, 50, I would say 55, maybe 60, who develop rather sudden, profound pain in the muscles, proximal muscles, so shoulders and hip area. And they might, before that, they may or may not have like kind of fatigue or just don't feel well or losing weight, some non-specific kind of symptoms. And they maybe go in and see their doctor, but their blood work's, unremarkable and nobody really picks up on anything. It might take a few visits. They may even go to the emergency room because it is very painful and they think they're dying. And somebody checks inflammatory markers and there's some blood tests that we can look at that tell us if your immune system is a little bit revved up, and they'll be high, not crazy high, but high. And not always, but generally you give that person some prednisone, like a steroid pill, and very quickly, within 24 hours, they will just describe like a shawl being lifted off of them, and they're just immediately better. And that's sort of the classic clinical picture of PMR. And that, again, men or women, generally older people, will get it. We don't know really why people get it. And there's a lot of, again, not everybody fits that story exactly, and there's a lot of overlap into other things, like is it really a giant cell arteritis, a vasculitis, or is this really a precursor to really have more rheumatoid arthritis? And we have some new therapies for PMR that we're using, and so I think we're just going to get better at treating and managing people with PMR in the near future.
Yeah, great. Well, we do have a number of viewer questions, so we'll get through some of those. We had an emailer, Vivek, ask, what causes scleroderma and how can we tell the difference between it and other conditions? Another difficult disease.
So scleroderma, genetic condition, primarily. It's autoimmune, but primarily driven by genetic disease. So basically it's luck of the draw. It's an activation of your immune system. There's been multiple different triggers that's been looked into, but no unifying trigger that you can say, hey, this happened, that's why you have scleroderma. How you differentiate is, so like other diseases, it is an autoimmune disease, but different autoimmune disease affects different parts of the body. Here what happens is, here you have inflammation classically of the subcutaneous fat. So just underneath our skin, the fat that we have, that gets inflamed. So scleroderma basically means rock skin in Latin. So that's basically what we see. We see that the skin becomes very, very tight. So very different from other diseases. Patients can't move their hands, but they can't move their hands because their skin is tight, not because their joints are painful. Now there are some differences. Sometimes you can have the same tightness in other organs, so that might be the predominant feature. I have a lot of patients sent in by the lung doctors where they have scleroderma involving the lungs. But almost always when you do a careful physical exam, you will at least see some degree of skin tightness also. Yeah.
Okay, good. We also had, we had an emailer, Jennifer, ask about Sjogren's syndrome. A family member was diagnosed with that. What is Sjogren's disease?
So that would fall under the umbrella when we talk about the term like connective tissue disease. There are many types, about a handful, I would say, lupus being the one that people are most familiar with. And Sjogren's syndrome would be kind of a type of connective tissue disease. So when you get these blood tests, for example, and your anti-nuclear antibody or ANA test is positive, and then they do more testing, you'll have some markers that might suggest this as an underlying process. And then clinically, as in everything with rheumatology, I always say we treat the patient, not the blood test, but we kind of know what you have, and then we use those blood tests to help us kind of paint the picture to decide what the next best steps are. But with Sjogren's, really the immune system attacks the glands of the eyes and the salivary glands. So people tend to have really intense dry eyes and dry mouth, which can, they can't wear contacts. They're have dental cavities, a lot of dental problems, and it's and many times there's a lot of fatigue, like profound fatigue associated with Sjogren's syndrome, and they might be achy, but I would say not that often do we see inflammatory arthritis, inflamed joints, but just more achiness. And sometimes that's kind of where it settles and we don't see much else. But like with anything, we have to kind of monitor all your organs to make sure that your immune system hasn't, progressed somewhere else. So sometimes people with Sjogren's syndrome can have some nerve problems and occasionally kidney problems, and they might be more at risk for lymphomas and things like that. So we kind of monitor people for that, and we treat symptoms as they go. So it kind of depends. Sometimes you can have Sjogren's and not really require medications that adjust your immune system, but just need kind of good observation or following.
Great. We got another email question, some great questions. This person has ankylosing spondylitis, and they take currently Celebrex or Celecoxib, but they say the vertebrae in their neck and back are fusing together, and they have a lot of aching in their hips, knees, hands, and feet, tired most of the time. Are these things normal with ankylosing spondylitis, and are there other medications that can be used?
So the description is classically of somebody with ankylosing spondylitis. So ankylosis, again, a lot of our diseases is all basically what happens is just translated Latin. So ankylosis is newborn formation. So that person mentioned that their vertebrae is fusing, I think, in the cervical spine, so basically over the neck. So that's very classical for ankylosing spondylitis. If somebody is having ankylosis or fusion on Celebrex, which is the first line treatment, in 2024, that person needs to be on a biologic agent. So the answer is yes, there are things that can be done. Usually the first line treatment is second line treatment rather, after failure of Celebrex, would be a class of medications called anti-TNFs. The most common would be a medication called Humira or related medications like that.
Yeah, so we do have other options,
Absolutely.
especially
Yes.
if you have signs of severe disease. So, great question. Let's see. Oh, we got a question about osteoporosis. We were talking about this a little bit before the show. So, Jennifer, a caller from Rapid City asks, is osteoporosis more common in women or men? And are there preventive measures that can be taken to reduce your risk of getting that disease?
So yes, osteoporosis is more common in women than men. My very general way of describing this is you get to put money into your bone bank until you're about 30, and after that you just get withdrawals. So if you did not build a good skeleton for whatever reason, whether it's genetics or if you're a young woman and you didn't get your period, you're an athlete, who knows. But if you did not have a robust skeleton in your early 30s, then as you age and after you go through menopause, you will start having a decline. And depending on if you're lucky enough to live to be 80, you're going to kind of run out of cash, so to speak, run out of bone cash. So men also get thin bones, but they just tend to have more bone to start with. So they get, it takes longer for them to get to the point where they have osteoporosis, generally speaking. Certainly, when we give people medications like steroids and that can contribute to osteoporosis that you maybe wouldn't have had otherwise or accelerate that process. In terms of things you can do to prevent it, I would say it is once you've built that skeleton, you want to maintain it. So being active and weight-bearing exercise, and particularly I tell people we don't lift weights enough. Like you actually really need to have muscles pulling on bone to tell your body to lay down more bone. You want to have adequate amounts of calcium and vitamin D available so that your body doesn't pull it from your bones when it's short. So, for a postmenopausal woman, that would be maybe 1,200 milligrams of calcium in divided doses and maybe 1,000 of D3, depending on, what their situation is. If they eat dairy, they don't need to take as much calcium as a supplement. But that is exercise, avoiding, hopefully not being exposed to medications that contribute to bone loss are probably your best bet. Some of it is, genetic to some degree, and you just have a small frame and you're going to be at risk. Other people just have a more robust skeleton or a little more fortunate.
Yeah, great. A follow-up question on the Sjogren's disease question, Vivek. We had a caller from Sioux Falls asked, is there an association between Sjogren's syndrome and rheumatoid arthritis?
Yes, so they are all autoimmune diseases. So when you have one autoimmune disease, naturally it begs the question, what brought it on? It was a dysregulated immune system. So that does increase your risk of basically every other autoimmune disease. So with Sjogren's, you can see in rheumatoid arthritis. You can also see a lot of neurological autoimmune diseases in the multiple sclerosis spectrum. So the answer is yes, but so are other autoimmune diseases too.
Not a special connection between those two particular diseases. Great. Well, rheumatology has changed dramatically in the last 40 years. Prairie Doc reporter Sam Schauer spoke to a rheumatologist at Monument Health about the advances and changes in treatments.
Dr. Cynthia Weaver of Monument Health finished her rheumatoid fellowship in 1989, and she has seen the field of rheumatology expand incredibly. She says one of the most typical medications to give back then was a lot of aspirin.
Medicines like methotrexate only got approved in the 1980s. The treatments prior to that time, a lot of times, was aspirin. Sometimes you'd give people as much as 20 aspirin a day, especially for kids with juvenile rheumatoid arthritis.
The next medication that patients would get were gold shots, which used gold to help with rheumatoid arthritis. Dr. Weaver says they worked well, but caused a lot of side effects.
Patients that responded to gold did pretty well, but it had a lot of side effects. It caused low blood counts. It could cause your bone marrow to kind of quit functioning very well. It could cause you to lose protein in the urine.
Dr. Weaver says in the early 2000s, the field changed when patients were introduced to biologic agents, which are small parts of a patient's immune system that are modified and sent back into the body to help the immune system not attack itself.
It was what's called a trap protein that inhibits tumor necrosis factor. And tumor necrosis factor is something that when your body produces that, it causes a lot of inflammation in the body. And so it was just a very discrete part of the immune system. But I have to say it was a game changer.
Since this change, Dr. Weaver has seen rheumatology grow and become an integral part of combating rheumatoid arthritis.
They used to tell people with rheumatoid arthritis, especially, that your chances of being disabled were about 50% in 10 years. And I never tell my patients anything like that anymore.
Dr. Weaver ends by sharing that rheumatology wasn't a fun medical field back then, as they never had medications to help patients. That isn't true anymore, as she says catching rheumatoid arthritis early is the best way to prevent it from getting worse.
Now it's really important for people to get treated early, because if we can help to slow or stop it before you have a lot of damage to your joints, then you don't go on to have a lot of disability or inability to do things. So it's probably a good idea that if you think that you might have something like that, or you're having persistently swollen joints or stiff in the morning, that you should talk to your doctor and maybe be evaluated for it.
Such a great perspective. I think rheumatology is so cool because you guys have so much that you can do for your patients now that what just wasn't true 20 or 30 years ago, right?
Absolutely.
Really cool. We actually had a caller from Sioux Falls ask a question that we could talk about, RA, maybe a little bit more. This person says they woke up today with their hands feeling very sore and stiff. I could hardly open them. My hand pain is usually worse in the morning, and exercise and topical medications have not helped. What might this be? What should I do? Jennifer, what would you advise this patient to do?
So if I heard you correctly, this has only been going on for
they said they woke up today with hands feeling sore, but the question says my hand pain is usually worse in the morning, so I assume it's been going on for longer than that?
Yeah.
Let's assume that.
I guess, I think you have to just start with, there's so much I don't know, right?
Yeah.
How old is the person, family history. But I guess if they're feeling that way, I would, go in, see your doctor, get an exam, have them kind of feel your joints. Maybe it's appropriate to check blood work to look to see if there's any inflammation or any other evidence to kind of support that there's more going on here, and then kind of go from there. It might be as, sometimes it's hormonal or reactive, or you had an upper respiratory infection and you're achy, more achy for a while and it goes away. To really be what we call, we draw lines in the sand, but they don't always work. But 6 weeks of persistent stiffness, inflammation, swelling, loss of range of motion, that's when you start to think, is this a chronic problem that's more in our world than some temporary problem? So I think that maybe some more, certainly it sounds like they should be evaluated, but we need a few more questions answered before I can give you much else. I'm sorry.
Yeah, great. We had an email question, Vivek. This patient was diagnosed with Crohn's disease recently, and they ask about what are my long-term treatment options. So you don't necessarily treat Crohn's disease, but you probably see a lot of patients who also have Crohn's disease, and you use a lot of the same treatments. So
absolutely.
Yeah.
So we work very closely with our gastroenterology colleagues at Sanford. Crohn's disease is an autoimmune disease, and like I alluded to before, you have one autoimmune disease, your risk of other autoimmune diseases goes up, so you can develop RA and Crohn's, but Crohn's on its own can drive a joint inflammation called inflammatory bowel disease associated arthritis. So just like RA, there are agents, biologic agents available for Crohn's disease. You want to fine-tune your biologics based on what the patient has. Does the patient have only gut inflammation? Then you have a subset of medications you can use. Do they have associated eye inflammation or joint inflammation? Then the treatment options, you can narrow it down to, this is going to work better because you have these two organ systems. But to answer the question, absolutely, plenty of treatments.
Yeah. And a disease that should be treated for sure.
Absolutely.
We had a Facebook question. I was diagnosed with sarcoidosis. Can we talk about this and the treatments? Jennifer, you want to take that? I feel like the last show I did must have been with pulmonary, and we got a question about sarcoidosis too.
Yeah, sarcoid is sort of tough because it kind of bleeds over multiple specialties. So it kind of depends on what your problem is. So for example, I recently had somebody referred to me who had a lymph node biopsy that had a pathologic diagnosis that suggested sarcoid. And aside from having some lymphadenopathy, there was really nothing to treat, meaning she did not need to be put on any kind of medication, and we simply monitor those things. Now, if you have eye disease associated with sarcoid or inflammatory arthritis or rash, then there's a whole list of things we can try. Oftentimes we have to try some of the traditional things that we use for many of our autoimmune diseases, what we call our disease modifying drugs. But there are biologic therapies that we use for sarcoid that are very effective. So it kind of depends on the organ system that's really giving you the most trouble, and that's usually where we direct our therapy.
Okay, great. We'll keep going with our questions. I've taken a variation of this question in my clinic, so I'd like to hear what you have to say, Vivek. A caller from Sioux Falls asked, is there a connection between the COVID-19 vaccine and autoimmune diseases such as lupus, or specifically the presence of autoimmune antibodies?
So, excellent question. I don't think there is a definitive answer just yet, but you have to understand what a vaccine does in a molecular level. So what a vaccine does is give a signal to your immune system to make antibodies. So it's basically there is going to be some degree of immune reactivity. COVID vaccine, there's a couple of different COVID vaccines, but the most common are the 2 mRNA COVID vaccines. What makes that vaccine more effective than something like the flu vaccine is just the way it works, the messenger RNA signaling. It drives a more robust immune system activation. So it's a better vaccine, but as a consequence of that, there is a slightly higher risk of autoimmune diseases. The risk is very, very low, but still compared to flu shots, the risk is slightly higher. But what we do see in the vast majority of patients is it does not lead to a persistent autoimmune disease activity. You can have a transient reactive phase. So you can have, for example, if it's joints, a reactive arthritis that once that vaccine's effect has worn off, the immune system goes back down to the mean. The only ones where you trigger something is somebody who had a pre-existing history of RA. We do see some increased risk of flares. Yeah.
Okay.
But the risk, overall percentage risk is much, very, very low. So overall, we strongly recommend vaccines.
Great, good information. Yeah. Okay, we had, let's see, a Facebook question. Jennifer, if your feet are sore and hurt all the time, could that be arthritis?
Right. So, of course, yes.
Yeah,
right.
sure, it could be.
But I would say if your feet are sore and hurt all the time. So when someone says all the time, I start to not think arthritis.
Sure.
I think nerve, right? Because pain that's constant, that's unaffected by activity or rest, that nothing you do helps, you start to think nerve pain, and I would think neuropathy potentially, as opposed to arthritis, where people would say, oh, my feet, when I first get up in the morning, they're really stiff. It takes me, more than 15 minutes, an hour later, I can't wear shoes in the house. And then eventually it's good. And I go about my day and I'm pretty good, right? That would be more, I'd be more thinking arthritis. Degenerative arthritis, the big toe, that is very common, that hurts. But again, it shouldn't be all the time.
Yeah.
You can have a flare up, but it shouldn't be all the time.
Yeah, okay, good. A lot of things can cause foot pain. We have 5 minutes left, so we'll try to hit a few more questions. We had a couple questions on this, and a caller from Worthington asked about fibromyalgia and whether is fibromyalgia related to rheumatologic diseases? Is it a mimic of rheumatologic diseases? How would you classify fibromyalgia?
So fibromyalgia is a disease that over time our understanding has changed quite a bit. It is not an autoimmune disease. It is a disease where there is an increased sensitivity to pain. So when somebody has fibromyalgia, there is no lab test that can reliably diagnose the condition. So it's going to be a question of ruling out things. So if the patient has more, and even with fibromyalgia, there are many variants. We have patients with fibromyalgia with predominantly joint aches or arthralgias. What we want to find out, either us or the primary care, is there an autoimmune inflammatory arthritis that's masquerading as fibromyalgia? And if it really is RA, I've seen so many patients where they come in with the tag of fibromyalgia, but what they do have is actually inflammatory arthritis. And why was it missed? Because they have seronegative rheumatoid arthritis. 30% of patients with rheumatoid arthritis have negative labs. Their inflammatory markers can be low too. So those are the ones where these new diagnostic modalities like musculoskeletal ultrasound can help diagnose between or differentiate between something like an inflammatory arthritis versus fibromyalgia. And it also, patients can have more nerve pain, so you want to work with maybe a neurologist to see, is there a treatable neurological condition? Is it something like a demyelinating disease like multiple sclerosis, which again is masquerading as fibromyalgia?
Yeah, so important to know the difference.
Absolutely.
Because they're treated differently.
Yes.
So great. Great caller from White River had a good question. What can be done to watch out or manage some of the side effects associated with these newer drugs coming out to treat rheumatologic diseases? So Jennifer, do you want to speak to that a little bit? That's probably a lot of the follow-up is talking about those things.
I guess I'm thinking they're referring to biologic medications. That would be the
that's what my presumption is too.
Other medications, and what I would tell people is, what the beauty of a biologic, it's an antibody. And it's an antibody's too big to eat or swallow, so we give it to you as a shot or as an infusion. And people might get an injection site reaction, a little red bump or tender bump, and we can usually work through that. But most people notice nothing. They don't feel bad. It doesn't go through your liver or your kidneys. It doesn't really bother you. Now, of course, it's augmenting your immune system so you don't attack your joints or whatever it is we're trying to treat. And therefore, just by virtue of everything we do in rheumatology, you're potentially more at risk for infection. So if you take TNF drugs, for example, upper respiratory infections might occur more frequently. If you're one of those people prone to sinusitis, we can kind of struggle with that. Or if your white count gets low with certain drugs, we kind of have to monitor for that. But in terms of what people feel, most people don't feel anything. They don't notice anything. And so it's our job. I always tell my patients, it's their job to get better. It's my job to get you on the right medicine. And then I look for badness. Like if something's not right, I'm going to be monitoring for that and paying close attention to that so that, you only have positive outcomes. But the nice thing about those drugs is they're really well tolerated.
Mm-hmm. Great. In our last minute, let's hit a couple shorter questions. We had a caller from Timber Lake ask about over-the-counter pain relief options for arthritis. So can you give us a quick answer on that, Vivek?
Perfect. So quite a few exist with varying levels of safety. Most of them, unless you have other medical conditions like heart disease or kidney disease or a history of GI bleed, would be safe for short durations of time, things you can get over the counter like Advil or Aleve. Short amounts of time, 5 days, 7 days, perfectly safe for the vast majority of people. Tylenol will have a better safety profile, something like arthritis strength Tylenol, 1 to 2 tablets, maybe a little bit more longer duration. But anything more than that, I usually tell my patients, 15 days of pain or more, not getting better, you need to see a doctor.
Yeah. And I always prefer to my patients, if ask me about whatever the over-counter the med is, I'd rather we talk about it because you're right, there are some chronic conditions that just make those things less safe. So
absolutely.
Great. Thank you both so much. The winner of our prize tonight is John. Thank you, John, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Searching for trusted medical information or looking for a doctor for your medical needs? Head to the Prairie Doc YouTube channel today to access previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
As a general internist who does primary care for adult and elderly patients, I talk to patients a lot about arthritis and joint replacement surgery. This type of surgery, also known as arthroplasty, is one of the most common types of elective surgery done in the United States. Knees, hips, and shoulders are the most frequently done arthroplasties, and most of those surgeries are done for severe osteoarthritis. Osteoarthritis, the most common type of arthritis, is due to wear and tear of the joint and becomes very common as we age. It often can cause debilitating pain and difficulty with function, which, for some patients, warrants the intervention of surgery. My patients often want to know, when is it the right time for a joint replacement? Well, no X-ray or diagnostic test can tell us that. The decision to go ahead with arthroplasty is very much individualized to the patient. How severe are their symptoms? How risky is surgery for this particular patient? How much quality of life did they stand to gain from a successful arthroplasty? While the orthopedic surgeon is the expert who patients should trust in talking to about the risks and benefits of surgery itself, sometimes as a primary care provider who knows intricately my patient's medical history, general day-to-day life, and feelings about medical and surgical interventions, I can be helpful in guiding my patients facing this decision. Often, I help nudge the reluctant patient who is suffering from severe arthritis toward choosing a surgery very likely to improve their quality of life. Rarely, I might help a patient with less to gain from a surgery reconsider its risk to benefit profile. A couple of years ago, I surprised myself by encouraging my patient, then 95, to consider hip replacement surgery. I never thought I would urge a patient in their 90s to undergo elective surgery, but this particular patient was in excellent health and rendered unable to do his beloved daily exercise because of his hip arthritis. The inability to exercise for him was a major problem for quality of life. He got his hip arthroplasty and enjoyed a couple more active years before his recent death. So if you are wondering whether you should go ahead with replacing that bothersome arthritic joint, there is no perfect formula that applies to everyone. But a primary care provider who knows you well can surely assist you in making the best decision for yourself. Thank you to our guests, Dr. Joseph and Dr. May, for volunteering their time to help us learn more about the advances in treating rheumatologic diseases. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us live every Wednesday morning at 9:30 on KBRK Brookings. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Pricks, tingle, sting, burn, or ache, these are all signals to your nervous system that something may be wrong. Managing pain, next time on Call with the Prairie Doc.
Hello, my name is Dave Heinck, and I've been a board member at Healing Words Foundation for the last 9 years. Well, my background goes all the way back to DeSmet, South Dakota, where Rick Holm and I were childhood friends. We were at USD together, and we've managed to stay close friends for our entire lives. And I spent the bulk of my career with Weyerhaeuser Company in the Pacific Northwest, and I led their production forestry research group. I also spent time on the faculties of Auburn, Virginia Tech, Purdue, and affiliate faculty positions at University of Washington, University of Idaho. And in retirement, I've spent most of my time in the nonprofit world in board service. When Rick and Joni were putting the foundation together several years ago, Rick would call and ask a question or two, and I usually had the answer, or at least where he could go. And so eventually, he and Joni invited me to be a member of the Healing Words Foundation board, and that's how it happened. The foundation and the Prairie Doc media production is really committed to truthful, timely, tested medical information. And there's a lot of information out there now that's either half truth or no truth. And of course, being a scientist by profession, we're always seekers of truth, understanding full well that the truth can change with additional research. Every dollar that's pledged or given to Healing Words Foundation unleashes an army of volunteers. The foundation and the Prairie Doc Media puts out really good stuff, very useful things. So there's a high return on the investment to invest in the Prairie Doc. For more information or to donate, head to www.prairiedoc.org or send your donations to Post Office Box 752, Brookings, South Dakota 57006. Thank you for support.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health, Dakota Dermatology, Vance Thompson Vision, Black Hills Medical Society, Brookings, Madison, Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Orthopedic Institute, Aberdeen Asthma and Allergy, South Dakota American College of Physicians, Cool Beans Coffee, Lake Poncet Sailing Academy, and Swiftel Communication.